Hello to our listeners. This is another episode for the 20-Minute Clinic podcast we've launched across North Cumbria and beyond, with the opportunity of bringing on board special guests to be able to speak about specific medical interests, specialty interests. And today, very grateful for Dr. Ross Kelly to join us and speak some about his own journey, some about his ophthalmology interest he has. Ross, thanks so much for having us.
Hi, Amit. Thank you for inviting me in. My journey started many years ago. I suppose when I left Dundee Medical School in 99, I didn't really know where I was going to go. And I took a very meandering path through general practice, general medicine. And it was only when I came to my time in ophthalmology here in Carlisle that actually I found where I wanted to specialise. And I disappeared out of general practice training, off up to Glasgow, had a great time there, and then realised actually I could combine both careers. Wow. And came back, finished my general practice training, and with that brought my ophthalmology experience back to Cumbria. And at that time, the wind of change was blowing in my direction, and I was able to become a GPSI. And that was back in 2010, I think, we set up the clinic.
Fantastic.
And it's been growing from strength to strength ever since. And so I spend part of my time in general practice as a partner here at Carlisle Healthcare, and part of my time as a GPSI here in Carlisle, down at Workington, and I do a laser clinic in the infirmary. So
Wow. It
keeps my interest every week peaked, and if I can do this until I retire, I'll be a very happy man.
Fantastic. I mean, it's a great thing. Paul, I mean, it's, great to hear that we can develop such interesting interests, if that's even a word.
Interesting. Yeah, I think that's the word. Yeah.
I'm intrigued though, Ross. Why ophthalmology? What was it?
That's what I was thinking. Why ophthalmology?
We've got probably some trainees maybe listening to us and go, actually, that's an interest, but what would perk my interest that way?
So for me, it was the toys. It was the laser.
Yes,
that's what we need. It was the phaco. It was all the bits of kit that I could get my hands on, and I love that. That's me. I was speaking to my wife this morning about what my personality suits, what career it suits, and ophthalmology is exactly that. I enjoy that one-to-one experience with the patient, and I don't think really you can replace ophthalmology with arm's length service. It is par for the course. You have to see the eyes, although there's lots and lots of equipment out there that will take pictures, and some absolutely stunning pictures. I still get excited about the OCT scan that we can use to image the retina. That didn't exist when I started ophthalmology.
Okay.
Wow. And as a piece of equipment, it's probably revolutionised ophthalmology more than any other bit of equipment. And so when I discuss it with patients, I still sometimes find myself getting quite excited about the detail, the 7 layers of the retina that you could only see under the microscope, you can now see in real time on the screen with a patient in front of you. So for me, that's what it is. It's the toys.
Do you want more gadgets now, Amit?
Well, this is it, isn't it? I mean, I'm intrigued as well myself. What would, if I've got a registrar or a trainee, even students listening in as well, what would you say to them if you could go back and offer advice to a younger self about how to follow this journey?
So I suppose my journey happened. It just happened in front of me without really planning it. Yeah. But for me, looking back, it's probably been the most rewarding career that I could have created is the portfolio career. Okay. Because I think listening to my consultant colleagues, they get bogged down with the hospital bureaucracy. In general practice, we equally get bogged down with the same work every week and the work that we're asked to do. And I escape a little bit of that because I have a foot in secondary care, primary care, and for me that keeps my interest. I don't get bored. I don't go to work on a Monday thinking, oh, not another day. Sometimes I do.
We all.
I think we all do.
Yeah.
But as a rule, I go to work on a Monday morning thinking, excellent, bring it on.
Fascinating. It's really refreshing, isn't it? Because we do often have those Monday blues sometimes are going in and whatnot, but knowing a portfolio career is very much one of several weapons almost in your arsenal you can use to make sure you've got that sustainable career plan. No,
and I think if you have, for me, general practice is the generalist part of my week, but the specialist interest is something that's in addition to that. And I think that's really important to be able to indulge a bit of your specialty interest, because you might not recognize that when you're training. You come across it as you develop your skills.
Okay.
And, you in terms of ophthalmology and ENT to a degree, you don't get much in the way of teaching as an undergraduate, and you might not get any exposure as an F1, F2.
True.
So if you get the exposure in part of the GP training, grab it. That for me was an eye opener coming into ophthalmology here. The teamwork was superb, the support was superb, the toys were fab. It was just, that's what I wanted to
Fantastic.
look at.
Is this
further.
something North Cumbria is really good at then, having the speciality alongside?
So I think
general practice.
things have changed, haven't they, recently, with the amount of rotations that trainees, GP registrars go through for specialty ones. But I'm hearing more and more it's really important to keep hold of those rotations, just because it gives you that exposure outside your general practice. And this is a great example, isn't it, whereby a positive experience has helped with shaping onward career. Fantastic.
Yeah, it's definitely been a good thing for me, I have to say.
Okay.
There's not a stale week that goes by.
No, good to know, I suppose, and it keeps things nimble, be able to evolve things. So thoroughly encouraged for be that registrars, even newly qualified, to get an opportunity to be able to spend time accordingly, soak it all up, and then use that to fulfil what kind of career to go through. Really, isn't it? I'm gonna pivot slightly.
Pivot.
And
He loves a pivot.
Loves a pivot.
Yeah.
And I'm going to broach a couple of questions for you, a couple of clinical ones. I'm really keen to hear your view on a couple of clinical scenarios that we've chatted about as well. Your angle as an ophthalmologist, as well as a generalist, as a GP, how you would cope. Just partly because it's interesting CPD, but I'd love to hear how you would go about things.
Okay.
So let's pick up one. I'm going with 46-year-old female presents to your 20-minute clinic, hint, with a concern arrayed about new floaters and a shadow appearing in her peripheries of her left eye.
Yeah.
Go on. What's in your head? I'm intrigued.
So flashes and floaters, very common, and it's a history that you're looking for, without question of a doubt. I think in general practice, we always know that the history gives us the detail, and this is one of those that you'll be hard pushed to examine the eye and find an intraocular cause for flashes and floaters with any degree of certainty. So the history is really important when you come to this, and you're looking for, what is it that could cause flashes and floaters? Well, your intraocular causes, primarily retinal detachment, collapse of the gel, the vitreous detachment. These are the two sort of most common ones. And then, of course, you have to sort of differentiate that in, could it be a central cause? Could this be a vascular event? Could it be migrainous? You're trying to figure out where you're going with this, and the history is what's going to give you that. But if we just say that it's new onset floaters, and flashes of light, and possibly a shadow in the vision. Now that to me points towards an intraocular cause, particularly if it's one eye. Now you'd be surprised how many people, when you ask, is it one or both eyes, and they look at you quite blankly and think, well, I didn't really check. It's so common, but it's really important to understand, if it is unilateral monocular visual disturbance, then invariably you're looking for an intraocular cause. If it's left-sided or right-sided binocular, then obviously that then transfers that more to a central cause. So it's monocular flashes and floaters. So we're narrowing this down. Could it be retinal detachment? Well, the two main risk factors for retinal injury are short-sighted, or previous intraocular surgery, so cataract surgery, for example. So if you've got a 46-year-old, unlikely to have had cataract surgery, so are they short-sighted? And there is a quick way to look at glasses, but actually just asking the patient is easier. Are you long or short-sighted? Or are you, if you remember going to your optician, was it a minus prescription or a positive plus prescription? And that'll help, because minus is short-sighted.
Absolutely, yeah.
Plus is long-sighted. So if they are a short-sighted eye, that increases your suspicion of a retinal injury or a retinal cause. And the theory behind all of this is that if you have a long-sighted eye, it tends to be large and everything's a bit fragile. Think about a balloon that's been overinflated. It doesn't take much to pop it. A long-sighted eye is a small rubbery balloon, so you can do whatever you like to it. They tend not to have retinal injuries, retinal detachments. But your long-sighted eyes everything's just a little bit thinned, a bit more stretched, so it doesn't take much to actually tear the retina. So even bungee jumping, for example.
Wow, really?
The gel, yeah, absolutely. The gel can deform itself as you go to the bottom of the actual stretch, and that can then pull the retina off the back of the eye. And as it does so, if you're short-sighted, you can tear quite easily. You get flashes, floaters, and loss of vision. So you can see that there are things that in the history that can be relevant, but not many people will be doing bungee jumping around Carlisle. So short-sighted eye,
Yeah.
new onset flashes and floaters, I think you have to think retinal detachment. Now, if you wanted to take that a little bit further and do a little bit more for your referral onto them to the hospital, because invariably that's where you are going to be doing this, or if you have the benefit of a minor eye service from your optometry colleagues, you can send them there for a more complete examination. But things I would be keen for GPs to do, or ACPs, anybody in primary care, would be check your vision. You could, if you wanted to, try a bit of peripheral sensitivity with confrontational fields. It depends on where you want to go. But one of the biggest deciding factors of does this patient need surgery when they come in as a referral into the department is establish whether there's a break, establish whether there's a retinal detachment, and is the macula on or is the macula off? Okay, so it's the extent of the actual detachment, because if it's a macula off, the vision's going to be very poor, and that's going to then lead to maybe surgery the following day or within the next 48 hours. If the macula's on, there's a bit more urgency to this, and they might go to theatre that day, because if you allow the macula then to come off, then your visual recovery afterwards is poorer.
Wow.
So these are the sort of things that from general practice through to secondary care, you can understand where a bit of urgency is required, but equally not everybody requires a referral, and that's really important. To me, the deciding one in your history was the shadow. If there's a shadow there, and they're quite certain there's a shadow, that escalates your likelihood of a retinal detachment. If it was just new onset floaters and flashes, you could argue that you could watch them. Now remember, as the eye ages, flashes and floaters become more common. After the age of 55-ish, the jelly of the eye starts to dehydrate, and if it does so, it can actually collapse suddenly, and that can give you sudden onset flashes and floaters. As that gel pulls away from the retina, it can tug on the retina and give you flashes, a bit like camera flashes in the corner of your eye, and you turn to look. But only about 10% of those will actually end up in a retinal injury. Majority of them will just be flashes and floaters, and the floaters will stay there. The flashes will actually disappear over a few weeks, and once you pass 6 weeks, you're back to a normal risk.
See, I'm using this as an excuse as to why I'm never going bungee jumping now.
I don't need an excuse.
It's fascinating, isn't it? When you really get down, this is a tiny little niche of ophthalmology, isn't it? Completely, but it's fascinating.
Really is.
The depth of the anatomy, the impact, and the aging process has on it.
Yeah, very much so.
Really, really fascinating, really interesting. So something to keep in mind, it's one of those almost heart sink ones you have, particularly if you're not used to ophthalmology, coming and going, oh, what do I do? How do I do this? But it's good to know that a big part of it is history taking, understanding what those risk factors are, unpicking those details, and making
Very
sure
much so, yeah.
in that referral to the eye clinic, to the hospital, it's clear on what those risk factors can be to really help our colleagues over there triage and assess accordingly.
Yeah, absolutely. No, it is. It's the eye clinic is a busy place, and actually, if you can highlight risk factors and your suspicion, then it kind of escalates their response, which is
fascinating.
important.
Fantastic, amazing. Thank you so much, Ross. I'm gonna. Should we pivot again? Pivot again, Paul.
He loves a pivot.
To
I feel like you need a jingle for your pivots.
We'll work on that.
For pivots,
we'll work on that. I really struggle with this element of it all, just about when it comes to eye drops.
Yep. Yeah.
There's a myriad out there. Some we are asked to prescribe by our secondary care colleagues. Some patients come and ask for.
Yeah.
What's your opinions?
So we, as a rule of thumb, are encouraged to direct patients to the pharmacy to obtain their own, say, for example, lubricant drops. The problem is that you have got best part of 100 different drops out there.
Yeah, it's
Can't be far off it anyway.
Wowzers.
absolute zoo. Isn't it?
And it's knowing what does what. And I think it's fine to redirect somebody to get their own lubricant drops if it's a bit of a dry eye and it's a wee bit of a nuisance, but nothing really terrible. And the likes of Hypromelos, that's your bog standard lubricant. But it does contain preservative. And that's a really important concept because preservative benzalkonium BAK is effectively toxic to the corneal epithelium.
Okay.
But it's in the bottles because it's required to keep that 28-day lifespan. If you think about what you do with a drop, you stick it in your eye, you might brush your eyelash, you might get touched on the skin, and as you then release the pressure, that negative pressure pulls bacteria up into the bottle, and it just ferments there very nicely over 28 days unless there's the preservative in it. Okay, so that's the reason why bottles have preservative. Yeah. But you'll see a whole host of preservative-free drops out there, and that's the first sort of differentiation between different drops. Preservative-free can be used more than 6 times a day.
Yeah.
So if you've got a preservative, run-of-the-mill lubricant, you're 4 to 6 times a day at most. Anything beyond that, you need preservative-free. Otherwise, you become toxic to the corneal epithelium. And there's definitely been a much greater number of preservative-free preparations available. The second thing is the type of lubricant. Well, the actual lubricant itself is not really a big issue. Most of them are very similar. But what's in addition to it is quite important. For example, in meibomian gland dysfunction or blepharitis, you still produce the right number of tears. The volume's not a problem, but it's the quality of the tear film caused by the lack of oil from the meibomian glands.
Oh, I see.
So you'll see some drops like Thea Lipid or Hylojule Intense. They all contain a little bit extra oil. So it's actually almost a delivery system for the oil. And that's why these are very important to have in mind. And then the last thing is to think about when you're prescribing is the bottle. If you have a look at the types of bottles out there, there is a huge number. From your basic sort of squeezy bottle that is multi-dose to your individual little vials that come in packs of 5 in a box to these very fancy multi-dose preservative-free bottles which have clever mechanisms within the bottle to prevent that suck back of bacteria. And that's why you can get away with the Hylojule, for example, the Hylo range, because it's got a very, very fancy clicker system which prevents that drawback. So, it's more than just the drop. And if you've got a patient who's got very bad arthritis, then these individual bottles can be a bit of a nightmare, although they often are much softer plastic, so they're easier to squeeze, but they're fiddly. Okay. Whereas the big clicker bottle is much easier to use sometimes, but does require a bit of pressure to pump it out.
There's so much out there, isn't there?
Yeah,
I mean,
absolutely.
Something as innocent as lubrication drops and the different formulations, if they contain oils and not preservatives.
Or even the bottle itself,
the
like
bottle
you're saying,
itself,
or the container.
You know what, that's
you wouldn't think of that.
Yeah, hugely.
It reminds me of asthma inhalers. The range of types of asthma inhalers is mind-boggling.
Absolutely, yeah. Is there a good resource, just to, as we begin to finish up our podcast, you could offer our listeners?
Well, there are a few. I actually happen to co-author some BMJ 10-minute consultation papers over the years, covering things like flashes and floaters, acute red eye. What else did I do? There's a few others over the years. So these are all designed for GPs in mind, with a 10-minute consultation, as they were called. So there's a clinical side of things, and I'm afraid when it comes to prescribing lubricants,
there's a project in that somewhere, isn't there?
There really is, because it's mind-boggling, the vast array.
I'll tell you what we'll do, Paul. We'll include some of these references in our
links.
Absolutely, that'd be really, really good to include.
More than happy to do that.
Very final question. I'm hoping to start something with this. Every guest that we bring on, we're keen to ask them this simple question, but I'm very keen on your answers and keen for yours, really, Ross.
You're going to want a jingle for this as well, aren't you?
We'll get a jingle for this as well eventually. So primary care is a busy place, as across the NHS, absolutely. What one thing do you think would be something that you would wish for to help improve your day job?
Well, that's probably quite a tricky one for me to answer, because I'm very happy with my job. As I said at the very beginning,
we found a happy doctor.
I am delighted with my job. I think for me, the frustration that I have is not being able to provide the service that I inherently would like to provide at times. Not always, but at times. And that's predominantly down to the structure that we work in, where we have to make ends meet in a finite budget. We struggle to recruit sometimes in the area, which is a real shame, really, because this is an area that I came in the country that I came to in 2001 with the full intention of leaving, but never have.
Wow. Okay.
I would like to see development of medical services for the patient at the heart of what we do. We all strive to do that, but I think sometimes because of the external pressures, we don't always achieve that. I think that would make me a happy person and make the patient a happy patient.
Yeah, it's a one that I think a lot of us can resonate with. Yeah, and something that I'll take on. I'm hoping to acquire a bit of a list of all these as forthcoming guests come on. I'm not sure what we'll do with them, Paul, but we'll.
Is that going to be the end of year Christmas
present
Christmas
for everyone? Present, absolutely. Yeah, something like that.
Bonus festive gift of a compilation of
definitely
inspiration.
Ross, I have to say, a huge amount of learning here. Even within a short podcast, this has been fantastic. Really fascinating stuff. And people would argue with me, why on earth are we doing a podcast on ophthalmology, which is the worst medium? But I hope I've learned definitely, and I hope our listeners have. And I would absolutely love it if we can get you back on again over the forthcoming months to delve deeper into the murky world of ophthalmology.
More than happy to. Because I very much appreciate that it is an area of medicine that is probably not visible for everybody. And
there's a pun there, isn't there?
Absolutely.
Hang on, do you want me to do the drums?
Yeah, go on.
There you go. Had to be done.
And you've just got to stick at it.
Absolutely. Amazing. Thank you so much, Ross. And Paul, always a pleasure. I look forward to next time. Thank you so much for listening, guys.